right, welcome everyone to August office hours. Appreciate y'all joining today. Can everyone hear me okay? Yes, okay. See the screen all
Yes.
right?
Yep.
Everybody can see and chat. We can see hello all, hopefully. As always, if folks have questions along the way, please feel free to chime in or use the chat function. And the recording, we're recording as always. So that'll be available on our website in the near future for folks to reference, or for those who couldn't attend today, they can use that as well to catch up on what we discuss. So with that, we will forge ahead. Normal policy and procedure updates, children's updates. We got some QMP and compliance updates. More discussion on the CES tool from last month to give you the final updates that were put forth by DOH, appropriateness criteria as well. Our redesignation update that's coming as of September 3rd, network training, and AHI website redesign. So with that, I will bring it to Jessica.
Hello. So I'm going to walk through a couple of things today. You have me for policy, children's updates, and then some quality and compliance things. So first, we're going to walk through a couple quick updates to assignments and referrals, comprehensive assessment, and our interpreter services policy. And then we just wanted to let everybody know in September, we should have the eligibility and appropriateness policy updated, quality, performance, and compliance, access to services, caseload ratio, and the children's core service and billing policy. That policy technically doesn't go in effect until 12/1, so I'm not sure if I'm going to put it out before 12/1. I did just write the first draft of that. So it says upcoming, it may be next month or it may be pushed out a little bit. Next slide. So assignments and referrals policy, this is an annual update to our policy. So there were no really huge changes, just some minor tweaks. One of the biggest things that we did add to this policy were that we can enroll members who are receiving early intervention services. This changed as of July 1st. So historically, we have not had any duly designated providers in our network, but you now no longer need to be duly designated. So if you have a youth that is receiving early intervention, they can also enroll in Health Home. Your responsibility with that is the same as it would be if you enrolled a youth with any other provider in place. So you want to make sure that you're coordinating with them, including them in care team meetings. So they should be listed on the care team. But it's going to be the same workflow as if they were any other provider. Another thing that we wanted to mention is that we do accept members who are looking for OPWDD eligibility that are not connected to OPWDD. So if you have a member, adult or child, because sometimes we do have some adults that need some eligibility and don't have it yet, as long as they are not enrolled with a CCO, so you would see that in ePaces with an RE code, they start with an I. If they have an I code, that means they're enrolled. If they don't have that code and they're looking to get eligibility, you can and should be accepting those members because you can work with them and work towards getting them eligibility and supporting them through that process. And then you can transfer them over, or you can enroll them and see where the best fit for them would be, and then you could discharge them out to a CCO. We can go to the next slide. The other thing we are looking at is that when we get referrals to the Health Home, we're looking sure to make sure that the contact information there, member information is there. There is referral source information. We look to make sure they have an active Medicaid, see if they have any RE codes, coverage codes that we need to follow up on. Sometimes we're going to get an abundance of information on our referrals, and sometimes we're going to get a bare minimum. It's dependent on who is making the referral. Sometimes we get a referral that doesn't have the SIN number on it. And it's a scanned copy. So once we figure out what the SIN number is, we can't then write it on the form to you, but we'll put it in the email. So there's going to be different circumstances where you're not always going to get an abundance of information with a referral. You do have the right to always ask the health home for more information from whoever is sending you that referral. We can contact the referral source to see if we can get it. But there are going to be times that what we get on that referral form, that is it. If it's coming from a doctor's office, a clinical provider, we should be getting some supporting documentation with the referral, but we also may not. If we're getting it from a community-based provider, we may just get very limited information because they do not have access to that member's clinical history. So that's just one thing to keep in mind when we do get referrals. We tried to send out referrals with the best contact information and what information we have, but it's not always going to come with all of the pieces that you may need to enroll that member. So we just want to remind the network that it is the responsibility of the CMA to make sure that they confirm eligibility and appropriateness for health home. That's always been the case. Historically, we've certainly helped out where we could. Again, if it's coming from a pediatrician's office or primary care, all that information should be there, but it may not, and we'll support to the best of our abilities. But even if it comes with that information, it's still incumbent upon the accepting CMA to ensure that that member meets eligibility and that appropriateness criteria. The other thing that I want to point out is that if a member needs access, let's say to a TBI waiver or PWDD, like I mentioned before, we should not be denying those members or denying those referrals because they may need a linkage with a care manager in order to get into those waivers. It's very complicated to get those assessments completed and get eligibility, and that member may need some support with that. So we don't want to deny members because they need these other things. We can be the linker to help support that member in getting where they need to be. So that's just another thing to consider when you look at referrals coming in. Does anybody have any questions on referrals? Okay, we go to the next slide. I think that was the last slide on referrals. I could be wrong. Yes, it was. Okay, so we did have an annual update for our comprehensive assessment policy. There were no real changes. The only thing that I really wanted to remind everybody is that your comprehensive assessment should be done prior to your plan of care. Now that we have a billing block with our plan of care, we are seeing a lot of plan of cares completed prior to the comprehensive assessment. While yes, your billing can go through, that's going to negatively impact your quality because your plans of care should be built on the needs from those assessments. So we just want to put a reminder out there that the comprehensive assessment should always be done before your plan of care because you're going to build a person-centered plan of care that's inclusive of that member's needs that were noted in their comprehensive assessment. And another thing through auditing that we noticed, not every time you go through a comprehensive assessment and all of the needs that are in that comprehensive assessment are going to be included in a plan of care because it is person-centered. There's going to be things that the member wants to address. There's going to be things that are not addressed. When we audit, just like the state does, they go through that comprehensive assessment and they know if there's a need. If there is a need noted, they will look to see if that correlates to the plan of care, and that is in every section of the comprehensive assessment. So we do the same thing because our auditing process mirrors what the state does. If there is something that's not going to be addressed because the member does not want to address it or have it included in the plan of care, it should be noted in the member's record that they do not want to address that. This goes pretty much for everything except the primary reason that they are enrolled in health home. So if they are enrolled in health home because they have bipolar disorder and they need a linkage to med management and housing, and they absolutely refuse to work on those things, that's what makes them eligible and appropriate, then you have to have the conversation about what they're doing in the program. So you want to keep those things in mind when you are building out your plans of cares based off of that comprehensive assessment. And this goes for everybody except our AOT members. They are court ordered to be here, so they're not always going to be the most compliant. Otherwise, everyone else that is enrolled in Health Home is voluntary. So we're going to take their feedback. AOT is a different story, but you should always be completing the comprehensive assessment before the plan of care. If there is a need noted in the assessment that's not going to carry over into the plan of care, it should be in the member's record that you know it's a need, but the member is choosing not to work on it at this time. You can go to the next slide. Did anyone have any questions on the comprehensive assessment? Okay, I did want everyone to know that on the comprehensive assessment, we're going to talk a little bit when we get to the kids slide. That is being updated on the children's side. And we're hoping for a January 2025 for that to be updated. So you're going to see another iteration of this policy. They're also working on a similar streamline of the comprehensive assessment on the adult side. I am not included in that work group, so I don't know when that's going to be, but that will be another modification to that policy when the time comes. So for interpreter services, this is an annual update. There are no changes to it. The only thing I just want to remind everybody is if anyone receives a referral either through the Health Home or a direct referral right to your CMA, and that member's primary language is not English, and you do not have a care manager employed at your agency that can work with that member in their primary language, you should reach out to the Health Home to see if we have another CMA that we can transfer them to. It's ideal that these members work with someone who can they can communicate with in their primary language. So if you're running into that, please reach out to the Health Home. We can see what we can do for that area that you're located. If we do not have a provider in your area that we can move the member to, we do have language link services that you can utilize. We ask that you just let us know ahead of time that you're going to be utilizing those services. It lets us know that we're going to be expecting a bill monthly and approximately what for. Does anybody have any questions on that? Okay. All right, so we're gonna jump into children's updates. There's gonna be a lot of bullet points, but not a whole lot of potential updates or just things that I want to make sure that we're touching base on. Just another reminder that we had HCBS audit review. We had some response to our CAP. I just want to remind everybody that we are in the process of updating our quality policy that will update the section on HCBS, how we audit HCBS, how we oversee HCBS. That policy is scheduled to come out in September. And at that time, I will probably have a separate mini meeting / training with our HCBS supervisors at that time to review those changes. And then there's also going to be a change on how our supervisors and care managers are trained for HCBS waiver. There's going to be some modifications to the Health Home. There's also going to be some modifications through DOH. There is potentially a shift in the UAS system where you go to do your CAN certification. There's going to be potentially in there a certification for HCBS. So you'll have to complete that certification before you can do a level of care. At the Health Home level, lead level, we have asked to see that training before it is deployed, and the state was agreeable to let us see that training before they implemented it. They are looking for a quick implementation. However, I have still not received that training, so I don't know what's in it. They did state that our Health Homes trainings are probably more robust than what they're offering. So basically, in so many words, you'll have to take both. You'll have to be trained by the Health Home and have to take the certification training. But more to come on that as I know more. You can go to the next slide. Again, as I mentioned, comprehensive assessment, we're looking at combining the Kansas assessment and the comp assessment into one assessment in the UAS. We are aiming to have that done by January of 2025. It is a very aggressive timeline, but it's something that we're working on. So I have not seen, other than a spec doc, I have not seen any sort of mock-up in the UAS to share with anyone. But hopefully that workload will be decreasing with that. As I just mentioned on the HCBS component for level of cares, there are going to be UAS training updates. So they're looking at that HCBS certification for completing the level of care. They are also looking to change how we are CAN certified. Right now we have the 0 to 5 and the 6 to 21. They are looking at making them two separate certifications. So right now, I'm sure the majority of us go in and pick 6 to 21. I know I do when I go in to do my CAN certification. They are looking to make those two separate certifications. So as I know more, I will let you guys know. Again, just a reminder on the early intervention piece that we can now enroll members who are also receiving early intervention. The core services billing policy that I alluded to earlier, that is going to be deployed for 12/1. I do have a draft version of that policy. It is what I have reviewed earlier. I think it was 2 months ago. I reviewed a shortened version of that. I may send out the draft version for feedback and questions. Again, I've seen 2 iterations of this policy so far, and it's not even finalized. So I don't really want to put anything out there that may change, but it might be good to get feedback from the network. It is a bit confusing. There are going to be waiver components in there where you can waive your in-person visits and do telehealth, but it's going to have to be after so many months of enrollment. Your frequency of your number of contacts per month is going to increase. And then there's also an increased level of interdisciplinary team meetings. I have not seen a spec doc from NetSmart or DOH for the back-end logic in NetSmart. Right now, you do not, let's say you have a complex acuity, you don't have your face-to-face, you just have one telephonic contact, the system blocks you from billing. Due to the complexity of the billing changes, those billing blocks may not be in effect. So if you erroneously put in a billing questionnaire, and let's say you didn't have your quarterly IDT meeting because your member is complex acuity, it may allow billing to go through. What that means is that we're going to have to add an added spot check of billing to ensure that compliance is there, because you may be billing for something that in fact isn't billable. So we do have some questions out to the state and to the coalition on that for clarification. Once I have those answers, I will let you know. High Fidelity Wrap, that's another program that's floating out there. I still do not have finalized policies from OMH for High Fidelity Wrap. Again, that folded into Health Home in January of 2024. Billing for High Fidelity Wrap goes into under the Health Home with those children billing questionnaire changes that we're going to see. Those will all fold in together. Once I have High Fidelity Wrap policy, I will let the network know. You will get that. Right now, we only have one CMA in our network that does High Fidelity Wrap. And I have heard that they're still standing with the early 2025 expansion of High Fidelity Wrap. So when the time comes for that expansion, we can have more discussion on that. Interdisciplinary team meeting forms. Again, just a reminder that everyone should be using those when you're having an interdisciplinary team meeting. Bottom left-hand corner of NetSmart is where that form currently is housed. We are working with a couple of other health homes and with OMH and DOH about High Fidelity Wrap. And if you're familiar with High Fidelity Wrap, then you know that there is a monthly child and family team meeting that has to occur. We may look at combining those forms, so as we move forward with expanding high fidelity wrap, it's only one form for care managers to be using versus two. Again, that's still up in the air, so we'll let you know as we know more. A reminder on the IRAMS referral portal and staff compliance. All of your staff trainings need to be kept up to date in that portal. So make sure that you have someone accessing that, removing members, staff as they leave. Also as those trainings are getting completed for new staff, that you're adding them to the staff compliance component. And then if you have anybody enrolled in HCBS, all of those members that you have enrolled have to have referrals entered into IRAMS. They all need to be electronic. So if you've already made a paper version, you need to go in and make an electronic version for everybody, even if that member is receiving that service. So if you referred them for HCBS respite and they're receiving HCBS respite, you still need to go in and do that short form. And then that provider will just accept it and needs to be in there electronically. The only youth that do not need to have anything completed for them in the IRAMS referral portal is if a member is family of one and they are using Health Home Care Management as their HCBS service. And that's it. They have no other HCBS services. Does anybody have any questions on that list of updates? All right, you can go to the next slide.
A lot going on with kids.
I got another slide. CANS 2.1. So as I mentioned a few months ago, the state kind of looked at all of our CANs after they shifted the language and the algorithm. And they stated that there may be an issue with the algorithm and they may be looking at adjusting acuity or complexity for our youth and looking at reimbursement rates. I have not heard anything on that, so I have no update there. And we haven't even talked about it at any of our meetings, so I feel like they're kind of at a standstill in how they're going to handle it. They did ask us for feedback on how the leads would like those funds processed if they were to come through, so we gave them our feedback, but I have not heard anything since then. The other thing is SPOA is completing HCBS level of cares. It is happening. So your local SPOA coordinator could be completing an HCBS level of care for members who are coming out of an excluded setting and as a transition going into HCBS and transitioning to your CMA. I strongly encourage everybody on this call, if they take a referral from SPOA that comes with an HCBS level of care, to tell your SPOA coordinator to please pass that referral through the health home and not to directly accept it. It would be as if you accepted a referral from CS that did not come through the health home for me to double check. We all know how great that CS referral process works and how we sometimes get the wrong information, forms missing, but you're on the hook for it once you accept that referral. It's going to be the same thing for that SPOA process. So if you accept a referral from SPOA that has an active completed HCBS level of care, I strongly encourage you to have them send it to me first. I will look it over and then I will send it out to you guys to pick up. If you pick up that referral directly from SPOA, I'm not going to know until it's too late because I won't see it in there until that member is enrolled. For modifications for technology, modifications and technology requests. Currently, we don't have any waiver youth in this process and none that I'm aware of that are going for any of these things. We do have a new process in place. I have not seen an updated policy from the state. It's on my radar. I know what the workflow is going to be. I just don't have it formalized in policy yet. Nothing from the state for me to formalize our policy, but the new workflow is in place. So just if you are going to have someone on your caseload that is going to go for a modification or assisted technology, to please reach out to me and then I can let you know the new process. One thing when it comes to social supports in NetSmart, just a thing to keep in mind, if you have a youth enrolled in Children's Health Home, they have to have a social support contact in NetSmart in order for that plan of care to pull and to generate into MAP. I know that Courtney has been emailing those one-offs. It's not a huge issue, just a reminder as you do your intakes to make sure that you're putting in that social support contact for children enrolled in health home, because we need that in order to have that plan of care generate into MAP so you do not have your billing blocked. Also, just a reminder that the wellness exam list was sent out, so please follow up with your members and families to make sure that you are getting those annual well visits. We are now getting that from the Department of Health, and it's for anybody who is under 21. So they may be enrolled in adult health home, but they're just sending that list for everyone enrolled under 21. So it was sent out to everybody in our network. If you had somebody on that list. Level of care billing. I actually just received notification that the spa was approved for this. A list was sent out to everybody in August who may be eligible to receive that reimbursement. This will start happening automatically for level of cares with the new MAP release that comes out. And it goes to the managed care companies to pay this out in October. So it'll come through MAP with the September release. In October, it will be paid for the MCO. Right now, everything going back to April of 2021 will be paid fee for service. So as we get those funds, we will let you know. I have still no timeline on that other than it is moving forward, but I still don't know when we will actually receive those funds. And just because somebody was on that list that I sent to you, that does not mean that you will be reimbursed for that member's level of care, because those level of cares, as a reminder, had to be completed on time. So if that level of care was late, you will not receive billing for it. And that will be the same moving forward as that billing transitions into MAP. Does anybody have any questions on this slide? Okay, next slide. Okay, I've been talking for half an hour. ACT referrals. This is just a little PSA for anybody who takes an ACT step down referral in Warren, Washington, or Saratoga County. We have noticed a pattern that if anyone is accepting an ACT referral for step down, so they're an adult coming from an ACT team back to health home, a child's coming from an ACT team back to health home, I strongly encourage you, if you accept one of these referrals in these 3 counties, to reach out to the health home so I can verify that their ACT segment was actually closed. We have had a few different circumstances come up where that ACT team did not have the correct segment in that blocks the health home segment from going in, and that ACT team continues to bill for their services, all while the health home enrolls that person and is billing for their services. And because there is not that ACT segment in there, it allows us to bill. And currently the instructions have been that the health home needs to void billing. So I strongly encourage anybody taking a referral from ACT step down into health home in Warren, Washington, or Saratoga County to please loop me in on that so I can verify that they are no longer receiving in those ACT services and being paid for, and that ACT team is not being paid for anymore, so we can bill for our services. Does anybody have any questions on that?
We want to make
All
sure
right.
that if you're billing for health home services, that there's not a duplication of billing on the other end, period. So please tell us.
All right, next slide. Only 8 more slides of me.
Well, Taylor's going to help
Um,
on these, right?
Yeah, so I'm gonna go over a health home plus overview. So we have been noticing that there are a lot of billing errors when it comes to Health Home Plus. So we just wanted to do a little refresher with the network on Health Home Plus, and Taylor is going to chime in as we walk through these next 7 slides. So we just want to remind everybody that when you have someone Health Home Plus for SMI or HIV, that member must have that diagnosis listed on their problems list and the primary problem. So if they're enrolled in Health Home for a single qualifying condition of SMI and you're doing SMI Health Home Plus, that should be reflected as the primary problem. Same goes for HIV. The only time would be very, I think we have one in our entire network person who has SMI and HIV, but they're going to be enrolled in the SMI Health Home Plus program, not the HIV Health Home Plus program because of their appropriateness criteria. That would be the only circumstance where that may shift. And again, there is one in our entire network. So that should very rarely would you run into this. The other thing is there must be documentation uploaded into the member's record confirming that diagnosis. So if you're telling me that a member is in Health Home Plus for SMI for bipolar disorder, there should be that external documentation in that member's record supporting that diagnosis. And the same goes for the HIV diagnosis. There has to be documentation in there. And that goes back to that referrals policy that I talked about. It is the responsibility of the CMA Health Home Care Manager to confirm that member's eligibility and have it in the record. The other thing that I wanted to point out is that not all mental health diagnoses meet the criteria for SMI. It is a specific set of diagnoses I have now added that to our eligibility policy that lists out the specific F codes that actually qualify someone for SMI. It is on the OMH website. The list was in our eligibility policy. I have taken it a step further. And when you see the iteration of that policy come out, it will have the exact F codes that qualify someone for Health Home Plus.
Lori
For
raised her
SMI.
hand. Lori raised her hand.
Okay.
Just quick question. A lot of times what we were doing is uploading the psyches report and using that for documentation. But I don't know that it's always being caught there as the documentation for the diagnosis. That makes sense?
Yes, we do look for that, Lori. So if there is an uploaded psyches, we will look for that. So yeah, so if you haven't heard from us, then whatever you're doing is right.
Well, I wouldn't go that far. It might just be you haven't caught it yet. But okay, thank you.
We did a pretty comprehensive review recently of our Health Home Plus billing. So we do count psyches. That's absolutely an acceptable form of uploading a documentation. And sometimes even on that behavioral health component, there will be, let's say it is a bipolar disorder, but there's another mental health condition listed first. We still allow that. It doesn't have to match 100. It doesn't have to be a 1-to-1 matchup when using psyches, but it has to be listed on there.
Great, thank you.
You're welcome.
And most importantly, be uploaded into the record to support the eligibility.
Okay, we can go to the next slide if there's no other questions. Okay, so I just want to go over what qualifies someone for Health Home Plus. So they have that SMI diagnosis, they have that specific F code that makes them eligible. So what is the qualifying criteria? An active AOT order, so you have that active AOT order on file. A CNYPC discharge within the last 12 months. So not 6 years ago, not 4 years ago, within the last 6 months. A state PC discharge, again, within the last 12 months. An expired AOT order within the last 12 months, because ideally these members are AOT step down, then Health Home Plus step down. That would be the correct trajectory for those folks. ACT step down, so they're transitioning off of ACT to Health Home. So they weren't ACT 7 months ago, they weren't ACT 2 years ago, they're transitioning down. You've also, if you live in Warren, Washington or Saratoga County, you've asked me if you can enroll that person and make sure that the ACT team has stopped billing for them. An enhanced service agreement or voluntary agreement. These are members who voluntarily go basically on an AOT order without being court ordered. It is a specific document that we're looking for. And there is clinical discretion of SPOA or MCO. You can go to the next slide. Also homeless, 3 or more psychiatric inpatient hospitalizations, 4 or more psychiatric ED visits, 3 or more medical inpatient visits with only a diagnosis of schizophrenia or bipolar disorder. Criminal justice, so there's a release from jail or prison and they need linkage to avoid reincarceration or have been incarcerated due to poor engagement. So if someone has a trespassing ticket or open container, these small petty crimes do not meet eligibility for criminal justice, or if they're ineffectively engaged. So no outpatient mental health services, and they have some psychiatric utilization. So that is the qualifying criteria for SMI. Does anybody have any questions on that?
Yeah, this is Jared from the Glens Falls Hospital. We were under the impression that criminal justice involvement also meant that the client that we enroll is either on probation or parole, even if they have been
Yes.
incarcerated more than a year from now, away.
Yes,
So
that
the-
is correct. You
Okay,
you
thank
can
you.
continue to do that. The policy per DOH OMH does state within the last 12 months, but if they are on, they come to you and they are on probation or parole because they need linkage to avoid reincarceration, or they were incarcerated due to poor engagement in services, that does count. We do need that documentation uploaded.
Yeah,
Thank
and
you.
we have that in writing. I worked with you in the past on that, Jared, and we got that confirmation in writing through OMH, so that is accurate.
All right, thanks.
Yeah.
Yep. Okay, you can go to the next slide.
Hi, Jess. This is Christine. I have a quick question also. Something that not all the time, but we do run into it semi-frequently is we get people that have come out of, like, say, a longer term incarceration. They do get diagnostic stuff while they're in prison, like mental health or whatever it might be. But because they've been incarcerated so long, we get them and sometimes things will not show up either on HCSNI or psyches, but getting hold of their health records from the Department of Corrections is next to impossible. Does anybody that's in the meeting have any experience with that? Like, way we can get hold of some of those medical records? Because, some of them would probably be Health Home Plus, but because we don't have like medical documentation or, the psychiatric documentation, it's hard sometimes to, to show that.
Yeah, so if they have a very long incarceration and we just enrolled someone with this, there's nothing in psyches, there's not going to be anything in HCSNI. They've been incarcerated for decades. There's not going to be anything in there. What we
Right.
can do is we can go back to the referral source. In this instance, we did ask them if they have any supporting documentation. If they don't, what we're going to do is link them to a provider in order to get a diagnosis.
Okay.
So then
Okay.
once we have that moving forward, because also, and I'll cover this on another slide, it's from the date that you determine them Health Home Plus. So there's like you're kind of chasing 2 timelines. One, you got to keep in mind the qualifying criteria potentially of the last 12 months, but then it's from the date that you deem
Yeah.
them Health Home Plus. So you have a bit of a moving target, but you can always work on with your supervisor, or again, reach out to me to make sure that that person is truly eligible and your supporting documentation matches.
Okay, that's great. Thank you.
Mm-hmm. So I just wanted to quickly jump into qualifying criteria for HIV. This represents a very small portion of our population, but we do have 2 Health Home Plus designated CMAs in our network that cover Health Home Plus for HIV. So that would be clinical discretion of the MCO or medical provider. So as you can see, SPOA is not included in this category. They are virally unsuppressed. they are homeless, 3 or more inpatient hospitalizations, or 4 more ED visits. You can go to the next slide, Travis. So this goes into supporting documentation. So you have your eligibility, so you have your diagnoses in place, you have your eligibility, your qualifying condition that matches, everything is matching up. So what does supporting documentation look like for all of these categories? What are we looking for when we audit? What is OMH looking for? DOH when they come to us in September? If they are homeless, this might seem self-explanatory, they have to be homeless. We have seen numerous claims come through for SMI homeless. The member is not actually homeless. They cannot be living in their home that they don't necessarily love, or a home that has mold in it that does not qualify them for Health Home Plus homelessness. They have to actually be Category 1 homeless. When we are working with members in this category, we want to make sure that we're adding that social health problem to the problems list. This will not deter billing, but you will get dinged on an audit for quality by us and by the state. So if you're enrolling someone who is SMI and homeless and you're not working on their homelessness in their plan of care, that is a red flag. The other thing to consider is that when you have homelessness, you may not have external documentation that you can upload from a shelter, something from a housing authority that you can upload that they're homeless but working on housing. There is the other option to have it on the plan of care. So you have the diagnosis of SMI or HIV, then you have your social health problem of homelessness, then you're addressing it on the plan of care. As long as that is there, you can continue to bill. If you have something from a shelter, you don't necessarily have to put it on the plan of care. But if you don't have something from a shelter, it absolutely has to be on the plan of care as a social health problem and something that you're addressing. When we are working with criminal
We have a
justice-
question.
Okay.
Oh, a comment actually from Stephanie. If anyone has clients at SOS and needs a letter, please let her know. With Code Blue season approaching, I'm sure we will see an array of agencies unhoused clients, and we're happy to help with proof of homelessness if needed. Thanks, Stephanie. It's rocking.
Thank you. That's very helpful. So if you have been contacted by the health home because you do not have documentation for these folks and they have spent time at Shelters of Saratoga, please reach out to Stephanie.
Thank you, Stephanie.
The other category is for criminal justice. We are looking for release papers, parole, probation documentation. If you have documentation from a database that says that that member was incarcerated, we need the source. What we are seeing is sometimes just and Taylor might be able to speak better to this, but like random screenshots of things that look potentially like a care manager might have typed it up, or it's not showing the source. It looks like anybody could be just making it up. I'm not saying that anybody is, but it doesn't look legitimate. So if you're taking something from Docs, or you're taking something from VineLink or one of those sources, you want to make sure that you have the source of the paperwork, the source of your data is also included in that screenshot or upload. Taylor, do you have anything to add to that?
That sums that bit up, but just one more thing to add on that, just ensuring that the date is on there as well. I've seen numerous, forms of documentation that don't have dates on them. We are looking for dates on those to make sure that they match up for the date of billing and that they're being renewed if applicable, once the time comes for that member to renew for Health Home Plus.
Yes, good point. So a trespassing ticket from, again, 2 years ago does not make you eligible for Health Home Plus for criminal justice. We do need that date because it should be active parole, active probation, release papers within the last 12 months, a recent arrest. That is what we're going to be looking for. And if you reach the end of your 12 months and that person continues to meet eligibility, let's say because they were rearrested or something, we do need that documentation with that date on it.
And these sorts of things are cross-referenced when not only by us when we look at through auditing, but when DOH audits, but also OMIG. I mean, we're going through an OMIG audit right now. They're looking back a number of years. We had to submit all supporting documentation that tied to any potential billable link for claims that were pulled for that duration for the time period for the SINs pulled. And if it's not there and it's not jiving, there's going to be potential payback. So it is looked at, it is cross-referenced. So we have to make sure that it's accurate.
Correct. And I'm going to touch on billing in a couple of slides. So we can go to the next one as we walk through our categories. So 3 or more medical inpatient hospitalizations with bipolar schizophrenia. Pretty self-explanatory. You have to have bipolar disorder or a diagnosis of schizophrenia. It's very, very clear. Those are the 2 qualifying diagnoses to be able to bill for this.
One input here, Jess, a lot of people are using schizoaffective disorder like interchangeably with schizophrenia. It is not. So just ensure that if you're using especially this one that you are, they have schizophrenia on their problems list and it is listed as schizophrenia in their eligibility documentation.
Thank you, Taylor. The other thing that we look for when we're going through this is going to be pretty self-explanatory because we're going to be able to see in psyches, the dates of those inpatient stays. So we're going to count back 3 over the course of the last 12 months or the date that you identify them as Health Home Plus, or we're going to be looking for hospital discharge paperwork for those 3 inpatient stays. Kia asked if a referral from docs would work as supporting documentation for criminal justice. Yes, as long as the docs referral has good information on it, and you upload it and it's easily identifiable, not only as the referral, but as Health Home Plus documentation. Because I have seen some pretty poor referrals from them before. So you just want to take a look at that, and you could always ask the Health Home too if you get a referral and want to know if it would count towards Health Home Plus documentation. 3 or more psychiatric inpatient hospitalizations or 4 or more psychiatric ED visits. These must be psychiatric hospitalizations or psychiatric ED visits. It's very, very clear that medical hospitalizations and medical ED visits do not count for this category. So the best way to support this would be documentation from psyches, because it'll tell you exactly what type of hospitalization or ED visit it was. Was it psychiatric or was it medical? Then we count back that either 3 or 4, the 12 months since the month that you deem them eligible. Or you can upload hospital discharge paperwork as it happens. Again, you're probably already collecting that because you're following our transitions of care policy. So that's probably already in there. And you're just going to mark it as Health Home Plus documentation. And then that's there. That's easy. That's concrete, black and white. We can count it. Go to the next slide. These other ones are very specific, and then we're looking for some pretty specific things. ACT step down, that's going to be that ACT step down. So it's going to be discharge paperwork from an ACT team. The referral from ACT to Health Home, as long as it has good information on it, much like those docs referrals, and it's clearly marked that that is your Health Home Plus documentation. Again, if you're enrolling anybody from ACT, step down in Warren, Washington, and Saratoga County, you want to make sure that you reach out to the Health Home to ensure that they have stopped billing. Enhanced service agreement is a specific document, much like the AOT order. There is going to be something in place that says enhanced service agreement. It's not just you saying one is there. There's going to be a very specific document that you upload. Clinical discretion of SPOA or an MCO. Again, this is going to be specific documentation. We are looking something from either the MCO or SPOA that gives them specific clinical discretion to move that member to Health Home Plus. Some SPOAs will just send an email, some will fill out a form. MCOs will just say an email, yes, they approve it. That documentation has to be uploaded into the member's record. Just because you got a referral from SPOA does not mean that that person is Health Home Plus eligible. The SPOA referral is not the documentation for Health Home Plus unless there's something that accompanies that referral, a form, an email, something that the SPOA coordinator is saying that they give clinical discretion. Again, you want to make sure that's noted in the record. And it's easy to find and it's labeled Health Home Plus documentation. Not just SPOA referral, if it is in fact including that Health Home Plus supporting documentation, much like the docs referral, much like the ACT referral to Health Home. We want to make sure that all of these documents are easily identifiable and findable, I don't know if that's a word, by the auditor and by OMIG, because if they can't find it when they're auditing, they're just going to count it as not being there and move on. AOT, easy, active AOT order that gets uploaded every year as that member remains on AOT. If they are no longer AOT and they go Health Home Plus for AOT step down, then we'll just see an expired AOT order in there. CNY PC discharge or state PC discharge, again, it's specific documentation and discharge paperwork from those facilities. It's not any inpatient discharge. It's one of those facilities. This can also be noted in psyches. So you could also, if you don't have that paperwork, as long as it is noted in psyches within the last 12 months, you could also use that. Expired AOT, like I said before, you have that member that's on an active AOT. So we're going to be looking for that. And then they move to Health Home Plus AOT step down. We'll be looking for that expired AOT order. Ineffectively engaged is a little bit of a complicated one. We are going to confirm that they're ineffectively engaged because we're not going to see any outpatient claims on their psyches, on their HCSNE, or we're going to see that flag that says ineffectively engaged on their psyches report. And then we're going to look for proof of those inpatient visits or those ED visits and that discharge paperwork. One thing I do want to say about using psyches as your documentation, there can be flags that are placed in psyches that are no longer applicable. So there could be a flag for ineffectively engaged, but when you look at psyches and you go down through the utilization is there or not there, depending on how you're looking at it, but it hasn't caught up to remove that flag. So you always want to, just because the flag is in psyches, doesn't necessarily that they meet the criteria, because the flag does not come down as fast as those claims get put into psyches. If that makes any sense, that might be confusing to everybody. But if you have any questions about supporting documentation, please let us know, run it by us, ask us, and we'll be happy to help out. Does anybody have any questions on the supporting documentation piece? Taylor, did I miss anything that you would like to add?
No, you absolutely crushed it.
Thank you. I have one slide left and then you will be rid of me. Okay, next slide, Travis. Okay, so completing your HML. We want to make sure that you are making sure that that primary diagnosis listed that you are billing for is SMI or HIV. This is extremely important. We just got our redesignation records. What I sent out to you guys is a very pretty version of what we got from DOH. They will be looking explicitly for documentation to support an SMI or an HIV diagnosis. It's right on there. It's what you're billing for. If you're billing Health Home Plus, we don't want to see asthma as the primary diagnosis. So that's super important that you're verifying your primary diagnosis. Then you want to make sure that you're selecting the correct category on question 12. This is extremely important. If you have a member who is Health Home Plus for SMI, please do not click Health Home Plus for HIV. You do not have the supporting documentation to bill Health Home Plus at HIV. I know it's an accident. You didn't mean to click it. It's all listed right there, all jumbled up. It's super important that you select the correct category of billing because that is the supporting documentation that they are going to be looking for. By they, I mean DOH, OMH, and OMEG. As Travis stated, we're going through our OMEG audit right now. Our OMEG audit, none of the records were Health Home Plus records that were pulled. So we have yet to be audited by OMEG for Health Home Plus. It will happen when the time comes. If you have a member who was SMI homeless and that's what you're billing for, but you accidentally select, let's say, HIV and homeless, and your documentation does not match that, even though it was just an accident, and none of us, no Health Home has gone through this. I cannot confirm that OMEG will be like, oh, okay, there is documentation there. It just doesn't match. Or they're just going to be like, they billed for this category. It does not match. It does not count. I cannot confirm nor deny that's how it's going to work, but we want to make sure we're being very, very explicit because when we are audited, that is exactly how they will be looking at it. So if you get to question, you're going to click your correct category in question 12, and then to question 12A, you can either mark yes, that the minimum core services were met, or no. If you answer no, you get that medium rate. And then just a reminder, anyone that you designate Health Home Plus, they are Health Home Plus for 12 months. So you get that high rate code for 12 months. Once that 12 months is up, you need to re-justify that they meet those categories. They can change categories. So after 12 months, let's say they're no longer homeless, but now they have criminal justice. So now you're going to change your category and you're going to re-verify with new documentation. As we audit, we look for new documentation at every 12 months to ensure that that person continues to meet eligibility. Then after that 12 months, if they no longer qualify for Health Home Plus, for 6 months, you're going to bill step down. So you're going to answer yes to 12, no to 12A for 6 months, get your step down billing. But because we have that CES tool, you want to make sure that you leave that Health Home Plus step down program in NetSmart for 12 months. Does anybody have any questions on that?
Still have your voice.
With that, thank you for tolerating me for the last hour. If you do have any questions at any time, please reach out. Between Taylor and I, we can pretty much answer almost everything. If we can't answer it, we will reach out to DOH or OMH to get an answer for you.
You guys
With
probably
that,
noticed we added a Health Home Plus spot audit to the quality notebook, so you'll be receiving that monthly as well.
Thank you, Jessica.
You're welcome.
You still have your voice. There was a lot. There's a lot of important stuff to go through. So I do appreciate you taking the time to go through it. Thank you all for hearing it. Now we'll go on to IA and CES tool revision timeline. We went through this last month. Talked about DOH updates to a draft appropriation criteria and CES tool that would go in effect as of September 1st. That draft has moved forward to an actual updated version for each of those documents that did come through this month just recently, and it is going to be effective September 1st. So I'm going to go through those updated documents in the coming slides. And then once office hours is done this afternoon, I'll be sending that out to the network. And then if the supervisors would share with your teams as appropriate, those documents and the guidance documents that go along with them. And then again, it's effective as of September 1st. These changes ultimately took a little bit of the input from the coalition and the health homes, some of the changes DOH moved forward with, additional to the input, and then some. So there's still some advocacy that's occurring, even though that this is happening September 1st, but here they are. Anything that's in red that you've seen in the coming slides are the changes. What's striped in black or what's going to be removed. Did it a couple times now, September 1st. So for the CES tool itself, you'll see the second column is the updates that are made. So this first significant risk factor was removed. So member has fewer than 2 identified people as supports. That's been removed from risk factor. The second category, a time frame of 3 months, has been added. And a recent change in guardianship, it's going to be, they had a change in guardianship or caregiver within the last 3 months is now what that category states. The next category, a time frame of 3 months, an additional specification on the lack of an alternative support a person has been added for this risk factor. So what was removed is that this recent institutionalization of nursing home placement of a member's primary support person, that's gone. And there's got to be the person as institutionalization or nursing home placement within the last 3 months, or the primary support person, and there's no other person to provide the same level of support. And then the last on this particular slide, this risk factor was removed, that the person has not seen their provider, PCP, behavioral health, etc. in the last year. Anything on this that anybody had? Before I go to the next slide. Again, I'll be sending this out to the network. The next one, this next update is it's going to have new guidance that's applicable for provider types. The member does not have what was striked out was a healthcare provider specialist to treat a chronic health condition. Now it's a member does not have at least one of the following, which would be a primary care provider, mental health provider, substance use provider, or provider to treat their single qualifying condition, which would be complex trauma, sickle cell disease, serious emotional disturbance, serious mental illness, or HIV, or progressive neurological condition. So that is the changes to the particular risk factor. The next one is striked from this particular category, which was the member or guardian was unable to appropriately navigate the healthcare system for that person's chronic condition. That's no longer there. The next one was altered. The time frame has been added to this risk factor to have 3 months be so the member's team care team member report treatment non-adherence was within the last 3 months, must specify which medications and or treatments are involved. So that's been the change on that one. And then there's language for this general risk factor. Language was revised to clarify preventable unnecessary hospitalizations or emergency room must be related to the member's chronic or qualifying condition. So has the member had preventable or unnecessary hospitalizations or emergency room visits related to their chronic or qualifying condition over the last 3 months? So that used to be 6 months. Now it's 3 months. And then preventable means hospitalization, emergency department visit was to the member's lack of adherence for access to treatments, appointments, or understanding of their chronic diagnoses. And then at the bottom, the member has documented safety concerns in their environment or community and does not have a safety plan in the last 3 months. So that's a big change there. So that there's not have a safety plan, and then that's not been in the last 3 months. So those are the big changes on this particular page of the CES tool. Anything here before I go on to the next one? Okay. On this particular update for the next page, there was a bunch of language added to revise, clarify that the member needs and does not have a safety plan, and adds a time frame of 3 months. So what was struck out there was there's an increase in symptoms, so that's no longer there. So now it says if the member has mental health diagnosis and they have experienced the need for crisis management responses within the last 3 months, which was once 6 months. So now that's within the last 3 months. Crisis management could be provided through a formal crisis response team or through their health home care manager. So informally is no longer part of that statement. And then it goes on, language has been added to clarify that both homelessness and risk of homelessness qualify in a new time frame of 3 months. So has the member had stable housing over the last 3 months? And have there been no evictions or periods or risk of homelessness within that 3-month time frame? So moves was struck out of that particular statement. Language has been revised to remove the time frame and only ask if a safety plan is in place. So if the member is documented as being in a relationship with chronic intimate partner violence, do they have a safety plan in place? So it doesn't say have they been able to follow one over the last 6 months any longer. It wants to know do they have one in place. And then language has been added to specify only behavioral health requirements connected to parole, probation are applicable. In addition, a time frame has been added to update to 3 months. If the member has been involved in the criminal justice system, have they been following the behavioral health requirements of their parole, probation over the last 3 months? So it's no longer 6 months, and it's specific to health and behavioral health requirements of parole and probation for 3 months. So those are the big changes on this particular piece. And then there's a guidance document as well that has been updated, which I'll provide to the network. Anything on this particular one?
I
No,
think
no.
everyone's head hurts, even though I know you need to give all this info, but the processing is a
Yeah.
lot.
That's why I'm going to send it out as well. But just want to go over it too, just so that we go over it. There's 3 areas that have been removed on this particular piece of the tool. Caregiver, member, understand frequency of outpatient follow-up, schedule and keep their healthcare appointments, have the reliable transportation to get their healthcare appointments without the health home care manager assistance. That's no longer part of this category. Does a member or caregiver maintain the member's medication adherence without health home care manager assistance? That's gone. Has a member or caregiver aware of upcoming recertifications for benefits and recertify without health home care manager assistance, such as Medicaid, SNAP, SSI, SSDI, public assistance? That's gone. And do the member or caregiver manage their day-to-day finances without health home care manager assistance, such as paying rent, bills, budgeting, etc.? That's gone. Managing ADLs with or without home care, personal assistance, caregiver support, that's been added. So a lot of changes. Again, a lot of things were changed. Some were put in without input by DOH as well. So that was Assess Tool. Again, September 1st. I'll let you all take that and go through it in the guidance document. Please reach out with questions. We'll continue to address as we can, as we know more from DOH as well. NetSmart has that stuff in UAT right now. We're looking at it. They've updated the templates in UAT, so that'll be ready to go live within NetSmart once stuff's all set. But they've got it in the test mode right now. Initial appropriateness, same thing. Things will be in red. Black will be what's struck out. September 1st is the changes. You'll see it through here. codes will be on the left-hand side. Updates are in here. Big thing, adverse events risk on the bottom here. Direct referral from Child Protective Services, Preventive Services Program, local county department, social services, admin for children's services for New York City, special ed program schools, children's suspension, truancy grade, failure, repeat grade, summer school, provider service data referral. So those would be adverse events risk, things to look at for appropriateness criteria. On the next one, there was an addition, skilled nursing crisis stabilization for recent inpatient emergency department psychiatric hospital detox. Then the second criteria box down, there's addition of qualified residential treatment, so QRTP program, community residential crisis. What was struck out on the third box, member or guardian is unable to appropriately navigate and connect to the healthcare system for members' chronic conditions. What was added during the last 3 months, the member has been able to schedule and keep their healthcare appointments, medical, psychiatric, and they do not know who their provider is and how to contact their provider. And then in the last box here, what was taken out, healthcare provider or specialist to treat a chronic health condition, so they don't have that. And then there's a bunch of stuff added that the primary care provider, mental health provider, substance use provider, that they have at least one of those following to treat their single qualifying condition. Next page here, added ED, crisis stabilization, and the first criteria. Next box, they struck out cannot access food due to financial limitations or ability to shop, access food site, dietary restrictions. Insecurity was added for food insecurity due to financial limitations, ability to shop, access food, dietary restrictions, emergency food assistance, SNAP, food pantries, Meals on Wheels, women, infants, WIC. Those were added. Next code, members fewer than 2 people identified as support, that was taken out. And then in the last one on 30 on the bottom, the member or caregiver, if the member is a child, does not have needed SSI, SNAP, etc., was taken out. Needs and does not have one of the following, and they listed Medicaid, transportation, access to ride, housing supports, etc., and lists off what those different types are. And then it carries on in the next, there's a whole bunch listed on the next page. Addition of in the last year, 6 months, there's no other person provided the same level of support for institute. I can't say the word now. Institute. There's no placement of members' primary support person. Institution. I can't even say the word. And County Local Department of Social Services. So those are in the quick overview. All the changes. So I'll get those sent out. Obviously not good news. Keep those updates to folks. Please reach out with questions. And we'll continue to answer as we have information. We're almost done, folks. Taylor had a couple updates on some reports just to help support a lot of this work that's happening with the changes. And then we'll be done for today.
Yes, thank you for being with us. So yeah, just a couple of updates to reports and guidance that was put out by DOH. So unfortunately, they had put out new guidance changing some dates. So for the plan of care, they changed that the initial plan of care from you have 60 days to do it to now you have 56 days to do it. They're doing this to better align with their policy and MAP. They're doing the same for the initial appropriateness. So you originally had 30 calendar days. Now you have 28 or 4 weeks, again, to better align with health home policy and MAP. And then the SES tool action due. So this is for your follow-up SES tools, your disenroll. If you get a recommendation of recommend disenrollment or more information needed, instead of having those 60 calendar days, you're going to have 56 calendar days to do those. So you may notice that your dates are a little bit different in Data than they have been, and that's because we've adjusted the reports to reflect these days for you guys. Next slide, Travis. And just one thing about the quality notebook. So as you guys are aware, on the quality notebooks, initial plans of care are marked on a level 1. They get that yellow highlight. Basically, as soon as they're overdue, they get that highlight and they're put on a level 1. We are starting to do that for annual plans of care as well. Obviously, you guys have been in the thick of it for a few months now, where those billing blocks have been into place. You've been getting the emails from Courtney for the reminders for the plans of care. So moving forward, starting in September, any overdue annual plans of care will also be put on a level 1 as soon as they fall into the overdue. You'll no longer have that like 60-day grace period before they go into a level 1. So just so you guys are aware, that'll be happening with the September quality notebooks. And then any level 1 items that are not resolved by the time the data is pulled for the next quality notebook, those will be moved into corrective action, and then I'll just request follow-up from the CMA supervisor on any of those corrective action items. Any questions on any of that? Alrighty, sorry, I know those aren't fun updates, but
Yeah.
I'll hand you back over to Travis now.
All right. So redesignation, September 3rd is our entrance with DOH. It's going to go a month. It's going to be a virtual. We're going to have a couple different meetings on various topics with DOH and different branches on our health, home, and performance. There's a good chunk of our CMAs that did have SINs pulled on different members in their organization. We did do spot audits throughout for those SINs. Each of those organizations has been reached out to. Thank you for those that have followed up. If you haven't yet, please do respond back. Please use the audit form that we provide. We encourage that that's used. It's the same audit tool that DOH utilizes ultimately. It's what they're going to use when they're auditing. We follow the same type of format so that we can be sure that we're looking and trying to find the same type of stuff. It's 60% of what our score is going to be for our redesignation is based on how we perform on our audits on the SINs across the network. So it's heavily weighed. So, we just encourage those folks out there to do it. We're really looking at close for our internal CMA as well, because we have a handful that are pulled for our internal CMA. Another piece of it is going to be each CMA supervisor. We had to submit a list of a contact for each CMA for supervisor to be reached out to. If you haven't been already, you will be shortly by DOH to have a survey basically to have an opportunity to provide feedback on HI Health Home, how we're doing as a support to you as a lead. So, now's your opportunity to give that feedback, and we look forward to hearing what you have for that feedback, and that's part of the process, and that's how we get better. So again, if you haven't had that contact yet, it should be coming very shortly. So please, again, utilize that link if you don't have that tool, the adult comprehensive chart audit tool. But really, take a look at those SINs and try and get that stuff up to snuff if you haven't done so already. It's heavily weighted, more so than it's ever been as part of the audit process. And that's all we have today. I know it was a ton. This is a heavy month, but there's a lot of information that we wanted to make sure that we got out for everybody. Any questions, anything anybody had for final thoughts, comments? Okay, well, thank you for all that you all do, and I hope you have a good Labor Day weekend coming up. For those of you that are getting geared up for it, and we'll talk with you all soon. Thank you so much.